Welcome to LifeStar Emergency Medical Services Training and Education Center presentation on cardiac rhythm recognition for EMTs and AEMTs. The reason we're providing this training for you is because at LifeStar EMS we do not use AED mode on our cardiac monitors. There are three reasons for that. First, the overwhelming majority of our ambulances are staffed by paramedics and AED mode would not be necessary. The second reason is because it takes time to take a cardiac monitor out of AED mode. If the patient's already on the monitor and we've already recognized the rhythm and made a shock or no shock decision, we don't want to delay providing that definitive shock to the patient by having to push more buttons and take the cardiac monitor out of AED mode. The third reason is because we employ high-quality EMTs and AEMTs at LifeStar who are fully capable of recognizing a cardiac rhythm and making a shock or no shock decision. So in the event that a BLS crew is confronted with cardiac arrest, they must be able to recognize a rhythm and make a shock or no shock decision. Before you experience any anxiety over the responsibility of making that call, the good news is we only shock two rhythms. The first rhythm is ventricular fibrillation, or V-Fib, and the second rhythm is pulseless ventricular tachycardia, or V-Tach. Let's take a look at an ECG and the components of the cardiac rhythm. This is a normal sinus rhythm. We can tell because right here there's a P wave. The P wave represents the atrial depolarization. Depolarization is another word for the contracting of the cardiac muscle. The next element of the ECG is the Qrs Complex, and that represents the ventricular depolarization, or the contracting of the ventricles. Once the ventricles have contracted, all the electrochemicals begin rushing back to their original position, and that is called repolarization, and it's represented here by a T wave. You'll notice our ECGs are printed out on graph paper that has both large and small boxes. The small boxes here are 0.04 seconds. When you put 5 of those boxes together, you come up with 0.2 seconds, and 5 of those large boxes comprise 1 second. You may have noticed that paramedics sometimes look at a printout and we're able to establish the rate just by looking at the printout without looking at the monitor. The reason for that is because in paramedic school we were taught to memorize the numbers at the top of the screen. The way we do this is we line up a Qrs complex with one of the big boxes, and then we count down large boxes, saying to ourselves 300, 150, 175 until we reach the next Qrs complex, and that tells us what the cardiac rhythm is. In this case, it would be somewhere around 62, 63 beats per minute.
Okay, here we see a typical Zoll M-series cardiac monitor. We've placed our patient on the monitor. We can tell that we're monitoring the patient through the defibrillation pads. And on the screen we see a very typical normal sinus rhythm. It is a sinus rhythm because we can see a P wave in front of every Qrs complex and then followed by the T wave. It's a very regular rhythm and we see P waves throughout. That is a sinus rhythm. As an EMT or an AEMT, you may find that you're on scene and you see a couple of other rhythms that are still interpretable. First, you may notice that the rhythm is very, very slow. It is still a sinus rhythm because we can see a P wave in front of every QRS, but it's very slow. In fact, we have a rate of 40 on this patient. A patient like this may have complained of having passed out or feeling like they're going to pass out. They might feel nauseous, they might feel weak, and there are people who are asymptomatic at this kind of bradycardia. So you need to be aware of whatever their medical background is. We have a rate of 40, that's quite slow, but there are people who go through life with that kind of rate. Another rhythm you may see and be able to recognize is atrial fibrillation. AFib is an irregular heartbeat. In this case, because it's over 100 a minute, This is an uncontrolled AFib. And the rule of thumb with irregular heartbeats is an irregular heartbeat is atrial fibrillation until proven otherwise. You might see a controlled AFib at a rate under or right around 100, and there are people that go through life with AFib with no serious complications as a result. Back to our normal sinus rhythm. Now, earlier in the presentation, I mentioned that there are two shockable rhythms. The first of those rhythms is called ventricular fibrillation, or V-Fib. When a patient is in V-Fib, their entire heart is quivering and there's complete disorganized electrical activity. And that's exactly what you see on the screen, disorganized electrical activity. Somebody in V-Fib is not going to have a pulse and they're not going to be conscious, so this is a shockable rhythm. So you would start CPR while you get ready to shock, and when you're ready to shock, you follow the recommendations of Zoll, which is the first shock should be at 120 joules, which when you turned on the monitor, it was already set to 120 joules. So you would charge the monitor up while you're doing CPR and clear the patient and press the discharge button. And you'll notice that the recorder is printing out what happened as a record of the shock, and hopefully that shock is enough to get you back to a normal sinus rhythm. If for some reason they're still in that V-Fib and you've already shocked at 120, the next level recommended by Zoll is 150. So you would charge again while you're doing CPR, clear the patient, and then press the discharge button. After you've shocked at both 120 and 150, all subsequent shocks should be done at 200 joules. Notice how the monitor is skipping directly to the right settings there. The other rhythm that you may notice that is shockable is called ventricular tachycardia, or V-Tach. This is an example of a V-Tach. It's a rate of 140. And the one extra rule that goes along with V-Tach and whether or not you shock is they have to be pulseless. If they have ventricular tachycardia and they still have a pulse, you would not shock that rhythm as an EMT or AEMT. At this point, you would have to make a decision about whether a paramedic is closer to you or you are closer to the hospital with regard to whether you load and go. You may also see a V-Tach that's quite a bit faster. This is a V-Tach in the area of about 184 to 185 beats per minute. A V-Tach at this speed is unlikely to have a pulse, but you still want to check the patient. If you find a pulse, again, you would want to either get a paramedic on scene quickly or go directly to the hospital, but you would not shock this rhythm if they have a pulse. If they are pulseless, again, you would begin CPR, charge the monitor, and discharge with the same recommendation for joules. Start at 120, then at 150, and then at 200. And hopefully at the end, you get back to a normal sinus rhythm. The last rhythm you're probably going to encounter at some time is asystole. Asystole is a flatline rhythm. You may notice some little blips and blurbs during asystole. That does not mean that the patient is likely to recover. When the patient has mostly flat line, it means there's no electrical activity in the heart and you're unlikely to recover the patient from this rhythm.